All right. So the name of our presentation is Contact plus Education equals Change, Ways to Identify and Reduce Mental Health Provider Stigmatization. And the reason that I chose Contact plus Education equals Change is that research has shown that, you know, of the 3 ways of reducing stigma, contact and education are the most effective. By themselves, they have a smaller effect size. Together, we're hoping to see a greater effect size. So the path we're going to take today, I'll do the first part. We'll talk about the education piece. We'll talk about what does mental health provider stigma look like, ways to identify mental health provider stigma. We'll look at a couple of assessments that are available. You can find them by doing a database search, and then also ways to mitigate stigma. And then Gabe will do our contact portion where he shares some photographs and statements that he's made, kind of a modified photo voice presentation. And then at the end, we'll kind of discuss like, well, what kind of change is happening here? What can we look at? So one of the reasons, you know, I wanted to share these statistics with you because the numbers are pretty significant. I'm sure you're all familiar with them, but I just kind of want to touch base with the statistics because that's, you know, when we look at creating change, we're looking at in the big picture, kind of on a systems level, we look at statistics, which don't give us the individual story, but they do give us the big picture. And so in the United States, for the years surveyed, this was a report by NIMH in 2017, 46.6 million adults have mental illness. 11.2 million of those have serious mental illness. And 33% of those experiencing symptoms of serious mental illness don't access mental health care. And so, you know, the next thing we want to think about is like, well, why? Why do the 33% not access mental health care? And some of the reasons are, you know, economic reasons. Can be anything from like lack of transportation, lack of childcare, lack of the ability to pay for mental health care. But a very significant factor is they're afraid. They're afraid of us as providers. They're afraid that they will be stigmatized within the mental health care system. Most likely they have experienced it at some point. If not within the mental health care system, then for sure in society. So that's kind of the why of why we're looking at reducing stigma and just kind of raising awareness about it. So this is what it looks like. And I'll let you just kind of read through the bullet points while I talk about a couple of experiences I had. When I was in my master's program, I actually had a professor say, you know, like, yeah, I had this woman come into my office. She was wearing a leather mini skirt and fishnet hose. And I looked at her and I said, that's a borderline. If there ever was one, get her out of my office because she's going to end up suing me. That obviously there was personalized language there and implying the client, you know, isn't going to change. And, you know, buying into the stereotype of a personality disorder. And then there were times when I was in class, it was in my diagnosis class, and, knowing my experience with Gabriel, you know, my son and his journey through the mental health experience that he's had, I walked into class, in my diagnosis class, and one of the students was like, oh, yay, today we get to talk about those psychotic serial killers and, you know, the schizo crazies. And I felt so much pain for people who have diagnostic labels that involve psychosis or serious mental illness and the stereotypes that go along with it. I think that kind of planted the seeds for this journey that I've taken in my dissertation research. And so, you know, these are the ones. And some of them, you know, you think about some Some of them happen most often like in the medical setting when we look at non-compliance. Gabe, do you want to talk a little bit about your experience with being non-compliant?
Sure. So I kind of take a special issue with a non-compliance label, as it is a way for clinicians and providers to exclude you from a practice and accessing like the services you need or mental health services in general. So the idea of non-compliance, especially like within my experience or my case, was I got to a point where I had been through every reasonable medication that didn't have wild side effect risk, and had a discussion with my the kind of I guess crystallizing moment or what have you for me. I had a conversation with my psychiatrist, and I didn't want to continue taking medication. At the time, she was suggesting electroconvulsive therapy, and I had no desire to do that. I had seen the short-term effects and wasn't really keen on the long-term effects either. And so when I was just upfront with her and said I don't want to continue taking medication, I'm just going to try and go for a while without, because at the time I was just going to kill myself in a year, no matter what happened. If things got better, great. If they didn't, I'm kind of over it. And she kicked me out of her practice immediately. I could have no contact. She left me with the month of prescriptions I had, and I was at the time taking some fairly high doses of benzodiazepines. And if any of you are familiar with the detox process for that, how dangerous that is, that is what being non-compliant will gain you. It is a really sticky situation for you as the person accessing mental health services, but it's also just a way to push difficult people out of a practice. That is just my experience.
All right, thanks for sharing that, Gabe. And I think one of the things that really came home to me was the relational power dynamic. Before I started working, when I introduced myself, I should have told you I work as a DBT therapist in a private practice in Texas, and I'm starting my own DBT private practice in Colorado, which is where I live. So because everything's virtual, I'm still working in Texas. But one of the things I noticed as I started working in this practice, I see a lot of clients who are unemployed because of the severity of their symptoms. They have limited financial resources. And so, I always dress really professionally, in the heels and the, hair and all of that and the makeup. And I started noticing that it created a distance between my clients and myself. And so I've really, one of the ways that I try and reduce the relational power dynamic is I dress down a little bit more, to be a little more casual in my presentation and my sessions. And I think anything that we can do to decrease that relational power dynamic really creates more of an equality between us and our clients. And so I think that's really important when we're looking at ways that clients feel stigmatized. Sometimes it's helpful to be the expert, and sometimes it's helpful to be on a more equal footing and more collaboratively with our clients. I'm also amazed at the number of people who still, to some degree, buy into the violent or incompetent stereotypes of people with serious mental illness. All right, so let's go on and see where do we go? So what are we going to do instead? When I was thinking about how I wanted to organize this, I thought about we're all professionals. We all adhere to some professional code of ethics, no matter what field we're coming from. And so I looked up a couple of the professional codes of ethics for different professions, and across the board, autonomy and respect for our clients and promoting autonomy for our clients is part of that. And when we use person last language, it's not respectful. When we imply that our client isn't working toward change, we're maybe not hearing where they are, seeing where they are, and especially we've already talked about the non-compliant language. And so what do we do instead? It's very simple. We use person first language, and sometimes it's like tying your tongue in a pretzel to use that person first language, but it's really important to put the individual before the diagnosis. I've noticed that even in my doctoral program, sometimes there'll be professors who, and they know I'm going to correct them on it, they'll slip into the old person last language, and I'll be like, okay, let's use person first language, and they're like, oh yeah, oh yeah. So it's really important because it does bring the individual to the forefront. And as far as the non-compliant label and implying that the client isn't working toward change, sometimes we need to find out why. Why is our client not working toward change? What are they stuck on? And provide encouragement. And with Gabriel and his desire to be medication free, which he has successfully done, no one ever asked him why, or until he found a therapist who was willing to work with him on that, provided him the opportunity and encouragement to take the risk and try and manage his symptoms in a different way. And that's part of autonomy and respect, is that even when we don't agree with our clients' choices, we have to consider them as long as there's not serious harm involved. So sometimes autonomy kind of goes against what we want for our clients and what our goals are for our clients, but we do have to respect what their wishes are. All right, as far as diagnostic label and appropriate discussion, we think about beneficence and non-maleficence, promoting good and not creating harm. So we go to person first language. And as far as discouraging appropriate risk, sometimes we don't want our clients to like, oh, you're not quite ready for that, let's put that off. It's really important to focus on collaborative goal setting to help minimize risk, but to also help them take appropriate risk. Developing new relationships when they've struggled with that, working towards getting a job, even when their anxiety levels have been so high they've not been able to be employed. And then being sure that we correct self-judgments in sessions. I have a client that every other phrase that comes out of his mouth is a self-judgment. And so we spend a great deal of our sessions saying, okay, that's self-judgment. Let's go back and rephrase that. Let's state the facts and avoid self-judgment. It's not helpful in the long run, creates a lot of harm. So these are some simple, just common sense things that we can do. I've already talked about relational power dynamic. This falls under justice. Justice and equality. Promoting collaboration. Gabe's going to talk more about collaboration in his portion of our presentation, so I'm not going to really touch on that right now. And then as far as the stereotypes of violence and incompetence, it's really important to expand our knowledge base. Part of expanding our knowledge base is attending trainings that talk about serious mental illness and stigmatization, like this training. I'm glad you're here. And also being in contact with individuals who have serious mental illness, so that we can see them in other ways and with other perspectives.
Can I jump in and share something on that?
So, yes. Yes.
On the violence and wildly inaccurate understandings of that. So to kind of bring this in a more accessible, I guess, language-wise. So because I work in a 911 system, one of our primary emergencies that we respond to is psychiatric complaints. I have responded to thousands of 911 calls in the last several years. 30–40% of those are psychiatric complaints. The number of times where either I or my partner have been assaulted or dealt with a violent person is, I can probably count it on one hand. A lot of it is the attitude and energy that you bring to those kind of situations. And I know that that's not something that a lot of mental health providers are familiar with, is the acute kind of emergent psychiatric situation. So that's my personal experience with it, and it may be different for everybody, but I can attest to that those kind of mistaken like concepts of people being extremely violent are very untrue.
All right, thank you, Gabe. So this is a list of 3 different stigma assessments that are available, that have been developed and initially validated or have been in common use for a while. The mental health provider stigma inventory is the one that I chose to use in my dissertation to assess stigma. And so we'll kind of look at that today and just kind of look at some of the points there. And the Opening Minds Stigma Scale was developed in Canada as part of their Opening Minds program. I think it's a really thorough assessment. And then the community attitudes toward the mentally ill is geared more towards just the attitudes towards the mentally ill within a community setting. Kind of like a lot of people, there's kind of the not in my backyard attitude, and that it kind of looks at that. And so I'm going to stop sharing this screen, and then let's look at this one. Oops. All right, so this is the Mental Health Provider Stigma Inventory. It was developed by Kennedy and Associates, and has been initially validated. There may have been some more work done on that. And so, if you kind of read through the questions, they're not things that we would probably typically do in practice. We wouldn't think like our clients are crazy. Clients with chronic diagnostic labels should not make their own decisions. And you can kind of look through and see where you fall with these things. So within our practice, a lot of times, our stigma levels are fairly low. I mean, as much as I've studied, researched stigma and my experiences, with family members and things like that, when I do the community, this one I do really, my scores are great on this one. When I get to the community attitudes, the CAMI, that's kind of where the sticking points are. And so, this is just kind of the tone that this one takes. So let's look at the community attitudes. Whoops. Okay, I never did that before. Close the window. Let's go back, show my screen again. This one. Okay. Okay, this is the community attitudes towards the mentally ill questionnaire. And you notice some of these are a little harder to answer in a way that's not holding some stigma. If you think about a woman would be foolish to marry a man who suffers from mental illness even though he seems fully recovered. Well, I don't know. We probably wouldn't agree with the mentally ill should not be treated, that we would agree that they should not be treated as outcasts. But then what about, is there a good reason for local residents to resist the location of mental health services in their neighborhood? Now, these questions are a little bit different. Residents have nothing to fear from people coming into the neighborhood to obtain mental health services. Anyone with a history of mental problems should be excluded from taking public office. So it's a little bit stickier. So these are some things, to think about. Those are ways that we can assess. It comes up with a score, and the higher your score, the more stigma is present. So it's kind of, what we're looking at. All right. These are some trends that I observed just for those of you who might be supervisors or counselor educators. These are some trends that I noticed in my dissertation research. There was an extremely high level of social desirability. I used the Marlowe-Crown social desirability scale, and about 60% of my participants scored in the high average and high category for levels of concern about social acceptability. That tells me that the scores that I got on my stigma assessments were probably not accurate. And so that's a huge question in my mind, is how do we deal with, as counselor educators and supervisors, our supervisees and students, extreme concern for looking like there's, like they think that we think they should look, that social desirability. And how can we open things up so that they can talk about their values, their concerns, and maybe their misconceptions they have about serious mental illness, in a place that's safe for them to do that. The training actually did decrease stigmatization. It was not statistically significant, but there was a decrease in scores. Some of the research that I looked at indicated that cultural shame might play a part in stigmatizing others. Some cultures have higher cultural shame around mental illness, especially serious mental illness. And so kind of just being aware of that in your students. Males were more likely to stigmatize and showed less improvement. So if you have male students, something to be aware of. The age that showed the most improvement in stigmatization was about the age that you see in graduate school, 25 to 34. And as far as your counselor education, something really unexpected happened. In my intervention group, I looked at your counselor education. I only accepted students with fewer than 28 credit hours, so they're like first year students, or students who were in their internship clinical courses, intern 1 or 2. So my first year students and my first year interns had a decrease in stigmatizing attitudes following the training. My second year interns their scores actually increased, which indicated that they came away with more stigma than was expected. So something to think about. Something might be going on between intern 1 and intern 2 that we need to pay attention to. All right, so when we come to contact, it's really important that personal contact is part of how we gain our perspective on serious mental illness and clients who are experiencing that. And so, that's just a recommendation by the recent National Academies of Science, Engineering, and Medicine conference. And then that brings us to the question that Unger and Associates asked, is like, if contact is supposed to be effective at reducing stigma, why do healthcare providers still manifest stigmatizing attitudes and behaviors? It's a good question to ask. I sit with people who have serious mental illness pretty much every day, and why is my stigmatization less than others? And first reason is because I have experienced equal status. I have experienced contact with someone who has serious mental illness in a position of equal status. My experience with Gabriel has totally informed the way that I interact with my clients. And so equal status is really important. And also level of symptomology. One of the ideas that was put forward is that stigmatization continues to occur because we see our clients, we're kind of like, the police and the fire department. We see people at their worst. They don't come to us when they're happy and things are going well. We see them in crisis. And then that can contribute to the generalizations and stereotypes that go along with serious mental illness. And so it's important to be able to experience contact with individuals who have serious mental illness at times when their symptoms are at a low point. So that you can see other aspects of them, and whether that can be done through, socialization or volunteer work, that's something to be explored. Qualitative research has shown that there's some common themes in the way that individuals are stigmatized, and these 5 themes are addressed in Gabriel's portion of the presentation. So they're blame and shame, disinterest, dehumanization, poor prognosis, and lack of collaboration and care. And those were developed from interviews with individuals who had serious mental illness and had access to the mental health care system and had experienced stigmatization. And these were the things that came from that research. As we go into Gabriel's portion, I just want to kind of make a statement about the content that's there. The handout that you were given does not include the photos or the personal statements that Gabriel's going to share with you. Those are proprietary and copyrighted materials, so I ask that you would please not take screenshots or in any way digitally record, other than the recording that's being done for this session, that you not copy that material because it is copyrighted. All right, so I'm gonna turn the time over to Gabriel. Any questions before we go on? Any questions, comments, anything? Okay, Gabe.
All right, so my section's kind of covering, as the title says, psychiatric subject, power and autonomy, and sort of the relationship that you guys as clinicians have to people like me who are or are going to access your services. So I think a good place to start off with is, this first bullet point talking about, your actions have a very, very direct impact on people's lives. And what I'm really getting at with that is that your decisions in regards to your client's care can change someone's life forever. So meaning if someone who is going to be hospitalized, and if there's interactions with law enforcement involved with that, that person can end up incarcerated. And I'm sure all of you are aware of kind of the long-term ramifications of that. Other things that I tend to think about with that is the ramifications of just diagnostic labels. This is something that I've touched on a lot in my undergrad work and in my degree so far, is that when someone is given a diagnostic label, it's not just that person that you have to think about. It is that label affects family, their interpersonal relationships. It affects them at a community level as well. And I think it's important to kind of be mindful of the actions that you take as clinicians. So on second point, the healthcare system, and no matter how you feel about it, it does not work. And this is part of the issue with the current privatized system in the United States, is that it creates, it creates inaccessibility for people. And I think it's important that we understand that we are working, and I say we, I work within the healthcare system. We work within a system that is not broken, but is the presentation of what privatizing a system of care does. It bars people from accessing it. It financially impacts them beyond a point of reason. And so I think that leads into, we want to help people. Me as an EMT, you guys as counselors and clinicians want to help people. But at a systems level, there are a great number of people that we're not going to be able to really help. And that is in part because we do work within a privatized for-profit healthcare system. And so I guess in short, be aware of your decisions and their broad ramifications for each individual. Do I have to advance the slides or? Okay. So if you guys would take a little bit and read through this. This is a statement I wrote on the blame and shame theme. And I think this kind of encapsulates the sort of one of the major problems there. So this is a photograph I took probably a week or so after I dropped out of university for the second or third time in 2014. I was at the height of probably some of the worst, or almost the worst, symptoms I experienced. I was definitely not really there. And a lot of these photos don't, directly mean anything within the broader context of the kind of theme, but they're part of a work that was me trying to visually represent my experience within the psychiatric care system. I was in my early 20s at the time. So here's my statement that I wrote that I felt was experience that worked well with the idea of dehumanization. And while you're reading through this, I think it's something important to note that this kind of dehumanizing behavior happens consistently within the acute care setting. And I'm not sure why. I'm not sure why it seems to be more prevalent there. And this is also true within emergency services and within kind of the ER setting prior to being admitted to a hospital. There are a lot of things that happen that are in my opinion, dehumanizing when it comes to people who are dealing with severe psychiatric issues.
I'm going to jump in here for just a second. One of the things that I found as I was doing my dissertation research is that current literature tells us that people with serious mental illness are looked at and dehumanized more than two other extremely dehumanized social groups and cultural groups. Muslim immigrants and illegal immigrants in the United States. And so the dehumanization of the mentally ill is pretty serious.
This photo is from, I think this would be 2011. And what you're seeing is all of those papers are prescriptions I was written within a 2 to 3 month period by a nurse practitioner I was seeing who was working under a psychiatrist. To me, at that point, I just felt like I was nothing beyond the diagnostic label that had been thrust on me, and that was it. I was just going to be stuck underneath the the weight of the medication. I just couldn't think straight. Was always tired. I didn't feel like me. And this is kind of this is from that, when we talked about earlier, the non-compliance, this is with that specific psychiatrist, and this was kind of the lead up to wanting to try and come off of psychotropic medication. And I know that that's a very controversial decision. It's not something I would recommend for really a ton of people. Only because it's entirely dependent on the people you're working with as the client. If I had not had a fantastic counselor that respected my decisions and wanted to just try something different, because nothing had worked thus far, I don't think anything would have ever changed. So this is still that same time period. This is probably 2013 or 14. And this project spanned several years. I think I started the initial photos that were involved in it in 2010 and moved throughout the process of making the photos over 5 years or so, 6 years. And this was just me writing letters to people. It was the visual representation of me writing letters to people. I had several friends who completed suicide in the early 2000s to 2010s, and I could never really explain it to their families or create any kind of clarity with that. And so I felt like I was going to end up that way. I was going to end up killing myself, and there wasn't anything I could do about it since it didn't seem like I was ever going to get better. Or even just get somewhat functional. And so I don't know how much of this really applies to the counseling, like people within counseling, but this is something that your clients are going through. Very much feeling that your psychiatrist is not interested. You're there very brief time, and it just doesn't feel like they're very invested. And I don't know if that's true outside of where I am in Texas. The healthcare system, specifically in the area I'm in, is really lacking. It's very much failing right now. This was probably about the time I started thinking about doing something different. was 3 a.m. in the morning. I didn't sleep a whole ton at the time, and I worked weird hours, and yeah, just the constant movement without ever moving. That's what it felt like. Felt like I was crawling out of my skin all the time. So this statement, it has it is a more positive note to some of it. And I think this is a major issue, and I don't know if there's a way to address it as far as not being different providers not being collaborative with each other. And that my experience is outside of long-term treatment centers. There, of course, providers are consistently talking to each other about what's going on with you, and they're able to kind of produce a better, I guess, treatment outcome within that setting. And I think we ended up with 2 of the same photo accidentally.
Sorry about that. We'll just skip on. Oh, hey, before we leave, lack of collaboration and care, I don't know, maybe this is a good place to, can you share the experience that you had at the residential treatment facility that you went to and in the wood shop? Because I think that's kind of, to me, that was kind of a key, it helped me in my practice with clients with serious mental illness.
And Ebony, yes, you are absolutely correct. It's it's very much a varied situation with EMTs and paramedics. There are people who are very sensitive towards those kind of experiences, or patients that are having severe mental health problems, and there are those that believe that it's not a worthy 911 call. Yeah, that kind of stuff it's far more prevalent than it should be, and it's a major problem. It's completely disrespectful. It's uncalled for, and it's one of those things we have to work towards as far as just immediately addressing that kind of behavior if you're present for it. But that's a shame. So the story of the wood shop, that to me was like really, I was at a long-term treatment center, and I worked in a wood shop as part of my just stuff I was doing there. Yeah. And so the person that ran it, I mean, he was not a mental health provider or anything. He was just a guy who knew how to make cabinets that they'd hired to kind of provide a way for us to kind of build stuff. And we did sell those things to help fund some of the activities and stuff that went on there. And it was amazing. He told me one day I was having a bad day, probably a bad week, honestly. He said it doesn't matter what's going on. If you want to come down and we'll build stuff, we'll build stuff. And to me, that in combination with just, we had a very open discussion constantly going in our kind of work group at that wood shop about how everybody was doing. We did like daily check-ins, and it was just a really open, you could bring anything you wanted to the table. And it was just acceptance. If you were not having a good day, or if you're having a great day, that's okay, or we can talk about that more. I don't know if that's specifically what you were thinking of, but that's, I think.
I was thinking of, yeah, I was thinking of, you know, there are times when I sit with my clients and they're having a bad experience, and I so, you know, like, I want to help. And I feel, because of your experience, I feel more strongly that it's important for me to say, you know, it's okay to not be okay today.
Yeah.
We can work on that, but it's okay for right now to not be okay.
Yeah, and I think that's
So,
definitely a major change that happened with that, and then also with my counselor here, was that it was okay. Yeah, like, you're having a terrible day. That's okay. It's not the end of the world, and we can work on that. But being able to sit with, you know, for my counselor to be able to sit with me and say, yeah, it's okay that you're not doing well, was a major turning point for me. So, I'm sure all of you know, or at least some of you, collaborative care is a wonderful thing where you are engaged with, or, you know, as speaking as someone in counseling, being engaged with someone that is collaborating with you towards your goals, desires, wants, and respects you as a person and allows you to make your own decisions and does not go over the top of you and puts you on equal footing with them is really one of the best things you can experience if you're accessing mental health services. It is, it's radically different from when you are put in a position or feel that you are just a diagnostic label or you are just a 30-minute medication management appointment. It is actually building a working relationship with someone to help you change the way you're experiencing life. And yeah, it's I guess really a nice, like, accepting kind of environment. And the non-collaborative care simply is just, if you've ever worked within a acute or crisis facility, a lot of that, you know, being defined completely by your diagnostic criteria, people being punitive for whatever reason, and not really allotting you autonomy to make your own decisions, and just, it makes you feel like a very weak individual, and I think that perpetuates that self-stigmatization and continues to uphold the kind of structures that maintain stigmatization from counselors and mental health care providers.
thank you, Gabe.
Mm-hmm.
So we've got about 5 minutes. If there are any comments or questions, just kind of like, what came from today? What are we leaving with? So if you want to share it in the chat feature, or if you want to unmute your mic and share a comment, you know, we'd love to have that. We're just hoping to create some change. I appreciate all of your comments. I've kind of been scrolling through, looking at them, and, you know, thank you for sharing your personal experiences. Some of them seem like they've been really difficult. And I feel for you. Thank you.
And Sarah Ramos, just to touch on their crisis assessment administrators comment. Yeah, this is a huge issue within kind of those, like, emergent services. Is there are a ton of people involved that do not have the training necessary, or even just the experience to have that kind of, it takes a delicate touch to help people through some of the worst experiences and moments of their lives, and it ends up causing more harm than good in the end. And thank you for sharing your story too. It's not easy.
I think one of the things that just through the last 14, 15 years journey through the mental health care system, one of the things that I bring with me into my counseling practice is that every time a client comes to me and says, I don't want to be hospitalized, will you work with me? I don't want to go back to a treatment facility because it was too traumatic. I believe them. I know that those experiences can be traumatizing, and that for me, that has to come into consideration when I'm looking at whether I recommend hospitalization for someone or not. I work my hardest to avoid it. Sometimes it's unavoidable, but the decision is always made knowing that that can be the experience that people have, the dehumanization, the sometimes the punitive environment that exists in acute care. I just try and stand in their shoes and think about what is it like to be, they like the experience that Gabe shared, strip searched, and possessions taken away, and can't be trusted with a toothbrush, and no privacy. I think about all of those things when I'm sitting with the client trying to make the decision of whether they need to go to acute care or not, or residential. So that's been a big one for me. All right, well, our time is up, and I really appreciate everyone attending. I appreciate your comments and the energy and the spirit that you brought with you today. And I look forward to maybe running across you in other places and other times. Y'all have a good day. Thanks again.
Thank you, everyone.
Awesome, thank you.
Bye.